The document may result from the advanced care planning process, and it will be referred to sometimes as an advanced directive. In Nova Scotia, there is referred to as a personal directive. If you're asked about the power of attorney, now is that something different? Yes, it is. Power of attorney refers to the management of an individual's financial affairs. No one knows like you, however, what you want for yourself. ACP, Advanced Care Planning, is about having a say, and it's about having a greater sense of control in your healthcare decisions and sharing that information with the people who matter most around you. Because maybe at some point in your life, you may not be able to. You cannot make your own decisions. It can happen to any one of us. Someone, that decision maker, will make the decisions that you would want for yourself. ACP, again, only comes into effect when a person is unable to speak for themselves, either because they are ill or they have some cognitive impairment. And
one of the
Allison, you're
things,
ready next. Yeah.
one of the things that we do in life, and we plan for our life, we plan for our banking, we managed our money, we bought insurance, we bought property. We made all the big decisions in our lives. Somehow we've shadowed away from death. But we all know, everyone in this room and everyone on the screen there are going to find at some point they will come to the end of life. And planning for that end of life is an important part of being able to have your say and having your family and those around you feeling very comfortable that their wishes are being respected. We often have heard people who in a medical situation refuse treatment. That is their choice. We have people who want you to go to extreme lengths, and that's what you would want to do. There are people who do not want resuscitating orders on them because they don't want to live in that state. That's a personal choice. And that's what's really important, is that we normalize it so we can talk about ACP, just like we can talk about our life insurance or where we want to live. Make it something that we all can talk about.
So by having the discussion, about your wishes for your health care, this provides what is needed. It provides that opportunity for family members, those who are closest to you, best friends, if someone in your family that you feel that close to, that person gains knowledge from you about what your services are, what supports you may want, anything that you believe is available to you prior to an emergency. I want to talk to you about the 5 steps of advanced care planning. And there's step number 1. Step number 1 means that you need to start thinking. Think about what is right for you. What is most important to you? What's important? Your values, your wishes, your beliefs. Think about these things first and foremost. Any options, any medical procedures that you may consider. Decide who will make the decisions for you if you cannot, but it's important that you have the conversations. And number 2, learn. Learn as much as you possibly can about whatever the illness might be when you sat in that doctor's office and he or she said whatever to you about your health. Learn about your overall health. This may include current conditions you want to better understand. I want to know more about this. I heard about it, but I need to know more about this. What does this diagnosis mean? You want to learn as much as you possibly can about whatever it is that you have been diagnosed with. And then number 3, I need you to consider choosing and decide. You need to choose and you need to decide. Who would speak for me? Who would speak for you? If you cannot speak for yourself, who would that person be? And as we said earlier in the conversations, this is not something that you're going to decide tonight or tomorrow and then you set and it's all done. It's a process. It's a time when you really have to think about this. You're going to have to learn something more, but you are going to have to sit at some point and choose and decide who would be that person to speak for me, to speak for you, if you cannot speak at some point in time for yourself. And then you need to talk. Number 4, you need to talk about yourself. Make sure that your family and friends understand who you are, and what your values are, what your beliefs are, what your wishes. That substitute decision maker needs to know these things. And not just the one person needs to know these things. Talk about it amongst family and write it down. Record it is number 5. Record your values. Write it down. What are your wishes and your beliefs? Record these things to help you remember and help them as they move along in helping you in that process. So again, the goal of this presentation is to help to normalize advanced care planning and make it part of the future planning that we already know has to take place sooner or later in our lives. I think there's a slide right now I'd like to be able to share with you. I'm not sure if we can do that, but we were hoping that we have a short little video that explains a whole lot in this. Is there any point, I mean, not point, but is there any chance of that happening?
Kate's online.
Okay. Kate, is that Kate? Is that the,
Sorry, is it this video here?
yeah.
Yeah.
Yes, it is.
Sorry. If other people change the slides, it changes for everyone, just so everyone knows.
Okay.
It's just loading here.
Thank you, Kate. this conversation that we're having tonight is an introductory conversation. And it's a conversation that is not it's not an easy conversation. It's a kind of a difficult conversation. We're talking about Nova Scotia hospice and palliative care. We're talking about very tender, sensitive issue of if I get sick, what happens? And in our community, in the Black community, the African Nova Scotian community, we, like many other communities, but I'm talking specifically to our community tonight, we tend to want to shy away from it. We don't really have that conversation that is much needed conversation. And we, especially as we get a little older, we realize, I wish so-and-so had said that. I wish they had wrote that down. We have these conversations. We've heard of people in our family and whatnot having these difficult times, but we don't know they didn't have the conversation to the point where they recorded it, they talked about it, and they wrote it down, especially. So tonight, I really wanted to make sure that we as a people can have that little bit of conversation tonight in terms of thinking about this, learning more about yourself and about your overall health, to choose and to decide to really talk amongst those people that matter most to you and make sure that you record. This thing called living well, it's so important. Take care of yourself. Live well. When we die, and that's inevitable, it happens to all of us, we can also die well. Now that's kind of difficult to say maybe, but there is such a thing as think about what is important to you in terms of your health right now. And it also should include what is important to you in terms of your end of life care. It's a gift to your loved ones to know that they honored your wishes. I'm going to end there. If there's any comments and questions and whatnot, we have plenty of brochures here. We have booklets here. We'll make certain that Hawk has them in the office. And we'll also talk to you about how you can get one yourself. But these are the things that we wanted to make sure that you get tonight. Sharon?
Yes, thank you so much, Melinda. And thank you, Anne, and thank you, Allison, because you know, what you've given us really is the theory. We also have booklets and resources that will be available to anybody who wants them at the Hawk office, and that's what, you know, we want you to know about that. And also, we're sending. I think Kate already has given you a link to the video. I want to sort of take the opportunity to dig deep in terms of people of African ancestry around the whole notion of palliative care and advanced care planning. I'll share. I'm going to share a personal experience. Many of you, my friends and colleagues, will know that I lost my mom in 2017. She was almost as old as the Queen when she passed. She was 95 to be 96 10 days later. She lived well until she died. And I think that's kind of the point that we're making here, is that you can do that. She did, obviously. No, well, not obviously. Those of you who know that, you know, she dealt with health issues. And as you get older, you do. We're all, some of us are already understanding what that means in our lives, you know, and as Black people, we are disproportionately affected by a lot of chronic disease.
Yes.
So, you know, we live with it, we manage it. but, and my mom did too. Where I'm going with this, and you know, and it does, it's not easy to talk about, but I'm strong now, having lost my mom so many years ago now. But I will tell you that one day I came home from mass, church, and it was a Sunday. She was literally sitting on the couch, and we were John and I were planning on going on a holiday, and my eldest sister was in town, and my other sister was coming to stay with us. In fact, she was going to go on vacation with us. So I had my eldest sister right there. She was going to take care of mom when we were away. That was the whole setup. They had the whole family thing going on, and it was a Sunday afternoon. And my mom opened the door, as she often does, to greet people. And you all remember her because she used to always be the greeter when we had our hockey events. And she was really, really good at that. And anyway, she opened the door for me, and I was busy trying to do something outside. I was telling her I need to do something in the garden before I come in. And as what my mom was used to doing, she sort of rolled her eyes and she'd say, "Oh, Sharon, you spend all that time in the garden." I was always being told off about that. But anyway, literally, she let me in. She made that response, and then she sat back down on the couch, and then she looked at me, and she sort of stiffened up, and I said, what's wrong? What's wrong? What's going on? And she said, "Oh, like my head is spinning," type thing. And I said, "Oh, well, okay, sit down." And she did. And literally within 30 minutes, I'd lost my mom to a massive stroke. And I lost her in the hospital, but we had got an ambulance and all of that. During the time that the EMTs were at the house, they were saying to me, "Do you want us to take extraordinary measures?" My eldest sister was sitting there. As you know, she was there in the house because she was going to take care of mom when we were away. And I looked at her and I said, "What? I can't do this by myself. What do you want to do?" So, you know, we didn't know. Nobody wanted to say. And I said, "Well, I think that mommy would not want us to take extraordinary measures. I don't think she would want to, you know," but I mean, I'm talking about, 3 minutes in which you have to make these kinds of decisions. And I said, like, "Sandra, you need to be with me to make the decision." And we looked at each other and we said, "No extraordinary measures, no," And my mom went on to the ambulance, and we made it to Dartmouth General Hospital. And during that time, they were doing CPR. And they looked at me and said, do you want us to do this?" And at that moment, I said, yes.
Yeah.
Because I was not signing up for that kind of decision in that short time.
Yeah.
When we got to the hospital though, and the CPR wasn't working, and I had to make that call.
Yeah.
All right. I can tell you from personal experience what it would have meant to me to have had the conversation that would allow me to be at peace with the decision that I made. Consequently, only months ago, I was able to, I was fixing up or sort of arranging mom's room, and many of you have been in there. And I found a paper, I found a document in which somehow I had tried to have this conversation with her, And she had written down, I only found it weeks ago, literally weeks ago, where she had written down what she wanted. And indeed, everything that I had chosen and that my sister supported me in choosing was what she wanted. And I am a woman of faith, and I have thanked God many times
Yeah.
for that, right?
Yeah.
But what would it have meant
Yeah.
to have had the conversation as
Mhm.
well as the documentation that would have allowed me
So
the
important.
peace?
Mhm.
And I share that with you because I want you to know how very important this conversation is and how relevant it is to our lives. Not only for us as children or as cousins or as, you know, but as ourselves, because I don't want my son to ever have any doubt about what it would be that I would want to happen at the end of my life. So I'm having gone through that, and thank God, having had the peace now, knowing what mommy wanted and knowing that I did the right thing. I do not want my son to ever go through the doubt or the question. I want him to know. And I want my grandchildren to know. And I want my husband to know. And I want my sisters to know.
That's right.
So I share that with you to try to bring it right down to life, to real experience.
Yeah. Yeah.
And I thank God that I'm strong enough to have conveyed that to you. But I invite you to share your thoughts about this experience, and to talk about maybe what you would need to get you to a place where you could have the conversation, you could have the documentation, and you could have the peace. So
That's so true.
loving my Hawk family, the floor is open to you.
Go right ahead. Anyone?
Oh, come on.
It's a lot to take in.
It's a lot.
It is
It's
a lot. It seems like a lot of information, and you're gonna walk through it. We did tonight, but it, like we said earlier. And I love the way that our sister Sharon, she made it so personal. I wasn't able to do that right yet. Because mine is still so very tender, but I got involved in this during the time that I was the caregiver, the caretaker, the decision maker for my mom. And there were so many things that I learned along the way that became so very relevant to me as I took care of mom. Then I had to wonder about taking care of me too. I was kind of losing myself sometimes in this. So I learned a lot in terms of advanced care planning, decision making, the love and the care that we give our parents. And I would like you to, just think about that tonight, and anyone here in the room, at the table here, if you feel you'd like to say something, or somebody online would like to lend something to the conversation or ask questions, certainly please feel free.
I want to say thank you for sharing, Sharon. That was very helpful. It's interesting. I had the same situation with my husband. That's how he passed on. So it's just such a coincidence. But I have been having those conversations with my daughter, trying to prepare personal care directives. But I was thinking, we talk about those things with our parents in mind, or a senior, someone really sick. And I wondered, do you have any thoughts about, what about younger people? My daughter's not married. She hasn't got a husband or children, anybody take care of her. If, you know, except for me. Do you have any thoughts around that or have, you know, any advice?
We certainly do, that is a piece of the conversation that, I often bring up and in our discussions and in particular in our community. Maxine, I think it is, was it Maxine? Yeah, hi, Maxine.
Hi.
It is a conversation that is very much warranted in our, sadly so, in our community because, we see a lot of young people's funerals that we're attending, anyone 50 and under, and we can be going to any number of funerals, for any number of reasons. We're saying goodbye to young ones in our family, so it is indeed a conversation that, tough to have. But it's, this type of conversation here tonight, I'm hoping that because this is only one of many that I would like to have as I move throughout Halifax, Dartmouth, as I move throughout the Nova Scotian Black communities in our communities, having these type of conversations. But Maxine, it is very much needed, that, and we'll try to keep having these very tender, very sensitive conversations with folks so that they can begin to have that conversation with their loved ones as well. And, like I said, that age, it's not just when you become an older person. Yeah, it can happen at any age.
Thank you.
Can I ask, we have a number of our HOC providers online, physicians, nurses, we have some in the room, who may well be in a position to advise our sisters and brothers, in the course of their work. And I just, without speaking about anything that's confidential, but from a general standpoint, are there any observations you all have as providers around this kind of conversation, this kind of work? Anybody? Dr. Leah, I'm gonna pick on you because you're here and you are back.
I am.
Want to say I am so proud of you. You all may not know Dr. Leah, but Dr. Leah was a member of the HOC student organization many years ago. She went to, as a result of her own amazing abilities and her drive, she entered Dalhousie Medical School with all of the HOC family behind her, and she is now practicing and back to Nova Scotia.
Yes.
So, Dr. Leah,
Thank
let
you
me
for
be the first online to say, welcome home, sister. Welcome home, sister. And tell us about, if you wouldn't mind, a little bit about your experience in this, something, whatever you're
Sure.
willing to share.
Definitely. I can give some background. So yes, my name's Leah Jones. I'm from Dartmouth. I'm currently still in Ottawa, but I'm coming home, as Sharon mentioned, in October, and I couldn't be happier to get back into Nova Scotia and serve the community that has served me so well and got to me where I am right now. So, so right now I work in primarily addiction medicine, but I did my training in family practice. And, when I'm thinking about my training, I'm just thinking about how important this conversation is, right? I've been on the other side of it, seeing stories like Sharon just shared of people having to make these split decisions in a moment of panic, right? And family members are so distraught and not sure. Nobody wants that for their own family members, right? Everybody wants, for their way out of this world to be as peaceful as possible, right? Not only for themselves, but for the people that care for them. So that's just one thing I was thinking about. Thank you for having this presentation for our community. The question about, having these conversations with younger people, it's certainly important. I think it's something that is not as much in the forefront of minds, right? Because of multiple reasons, right? As we're younger, we're not thinking about that as much, right? Because we don't have those comorbidities as we get older. However, I do think it is a really important conversation to have. People who are suffering from different comorbidities at a younger age should be having these conversations with their family doctor, right?
Yeah.
If you're privileged enough to have a family doctor, these conversations should be happening, every couple of years, right? So those are some of my thoughts on it. It's not a perfect answer, I understand, but definitely, I think everybody should be thinking about it.
Thank you. Rhonda? Yeah.
She's unmuted.
Okay.
Sister Rhonda.
Hi, Rhonda.
Yes. Hi, good evening, everyone. Can you hear me?
Yes, we can. Yes, we can.
Mm-hmm. Okay, because my connection is a little wonky here, but no, I just wanted to say thank you so much, Sister Melinda Day, and Sharon, and everyone that's there presenting on this evening. It's something I've been thinking about more and more as we live in a multi-generational home, and my mother's getting older. But as I think through this, I think just like Dr. Leah had mentioned, it's something that we need to think about no matter what age we are. And we really don't. I think because of some of the other pressures that we have in life, especially as people of African descent, it's just not something we tend to think about planning for. And that kind of goes along with, wills and estates, planning, life insurance, you name it. Preparing for the future in that way is not something that I think we typically do enough of. So this is a really important conversation, and I'm learning a lot this evening. It's a difficult conversation. I think that's part of why we don't go there. We operate a certain way in community, and we're always there, for our elders as much as we can. I think it's a cultural thing as well in terms of how we live with each other and how we handle these things. But this piece is so important because those decisions can really make a difference in terms of, how it impacts you as well as an individual making those decisions. That's why that first voice story that you gave, Sharon, is so important and really puts things into perspective for me. So thank you for that. I'm definitely going to be, making my care plan for my family and for myself because you've touched my heart. So thank you so much. Keep doing this. I think it needs to be widespread. And having you there, Melinda, talking to community, representing, first voice is so important as well. So please keep that going and let us know how we can support that moving forward, because I'm really interested in that, and I know we all are. So thank you.
Good, Rhonda.
Thank you,
Co.
Thank you
Thank
so
you,
much.
Rhonda.
Thank you so much. Do folks have questions about we have lots of people from Nova Scotia Hospice Palliative Care here. Do you have questions around that piece? Anything that they may be able to tell you about? At the risk of cutting somebody off, I'm going to ask about how the health system would help you
make decisions if you find yourself in this situation? Do you, for example, you know, if you're in an ambulance situation, that kind of an emergency situation, is there training? And Elizabeth, please jump in too. Is there training that sort of would tell a professional how to manage these situations? Are you aware of that?
No, I can speak to my own experience in this one, in the sense that I had a hip replacement last summer. And I was given at the hospital, it was about 8 or 9 pages, very repetitious. It was intended to be what were my wishes. Well, it was so lengthy, so repetitious, so confusing. I put my name on it and gave it, said here, I didn't feel like that. That was not, I was in agony. It was not the time to bother me with a piece of paper. And I thought to myself, and I've said it many, many times to healthcare people, that is too confusing. We have to get the message out beforehand. I have a question to ask. I think Melinda did a phenomenal job. Phenomenal. And I would like to propose, and it's up to you, Melinda, you hold the answer. I would like to propose that we record Melinda doing a podcast and put it on our website so that all Nova Scotians could have a look. All your African communities would see you talking to them. Would you be willing to do that?
I would be very.
All right.
You've already had your interview.
It may take a little while to get, we'll have to get the funding. We have to find the funding first.
ways that we can do it.
We're nonprofit, we have to find the funding, but I do believe that certainly
Yeah.
we could record this. And then, you know, people in Guysborough, in Sydney, in Yarmouth,
That is what we.
you're reaching the community. And I think that we can push it a little further and have you join her in a question and answer type of thing. It would promote more discussion. Would people would the audience like to be able to just, at your own convenience,
Everybody's agreeing.
watch that? All righty then. Okay, my commitment to you then is that we will try to get this done before the holidays, before Christmas rolls around. Hopefully we'll have it
Something for the
on.
new year and the winter.
Exactly, yeah.
I was just going to respond to your question about the personal directives. There's a much lengthier package. I think it's overwhelming to get into whether or not you have a designated decision maker or whether you have an assigned one by the courts. This is the directive that Anne was referring to. If you go into the hospital, they will ask you to complete it. Oh, sorry.
Right. It says, let's talk about.
Let's talk
personal
about-
directives.
And wherever you go, you will, when you're talking, there's many different forms in the back. Excuse me. We're not used to being quiet this long. There's 7 pages at the back of this. That is the advanced care plan. Now, I will tell you, and I don't feel I'm betraying anybody at all. In order to maintain a personal directive, you must write your wishes down and designate your delegate. It doesn't have to be on this formalized form. Thank you. It doesn't have to be on the formalized form. It just needs to be recorded with a witness. Now, the witness cannot be the person who actually is going to be your delegate. So for example, and I'm going to use just that personal, my delegate is my husband, but I have indicated that I would want my children consulted. So you can make it as a very personal message, as long, it could, you know, as they say, you could write it in the back of a serviette in a restaurant, but as long as it's witnessed, it can be recognized and respected as your personal directive. Okay, and I'm just going to add something that may not have anything. There's been a number of conversations. I work with the National Association of Canadian Canadian hospitality care. And one of the things that has come in recently, because it was not part, when MAID came in place, you were not allowed to designate. You could not have MAID. You could not have MAID if you were incapable of making decisions. Since the situation a few years ago, when you remember the lady who chose to take her life because she knew she was going to pass, that is no longer the case. Now, if you want to put in your care plan that if I meet the criteria for MAID, you can't just have people, but if I meet the criteria for MAID, my delegate can assign it based on the fact 2 doctors would say, yes, this isn't going to get any better and the end is in sight.
So MAID, for our sisters, what does that stand for?
MAID is medical assistance in dying.
Right.
So, and it's fairly common here in the province now, it's fairly common all across Canada, but originally people had to choose to die before they lost their capacity. And now they don't, that now you could just designate that if I'm unable to speak, you can speak for me. And if 2 doctors agree that my days on earth are limited, they can make that decision. Yeah, it's much more common. That is not something we talk about, but people who are suffering, it's a kind of suffering. And I think one of the data pieces that I think is so important is that less than 10% of us will die suddenly. Most of us will experience declining health, frailty, and 70% of us, when we come to the end, will not be able to communicate. So that's I've experienced with both my parents, and it's a heartbreaking situation.
Yes.
And we had enough among us to be able to pull it together, but would have been much easier if I knew this is what Mom would want.
Oh, yes.
That's, Mom's mom till she still is.
Mom
Will always be Mom. I had the privilege of working at Laura Day. No, what a wonderful woman she was. Yeah, we used to do the lexicons on Friday.
Yes. Thank you so much. I wonder, Sister Elizabeth.
Yeah.
We make assumptions, I guess, that because we share African ancestry, that we have many of the same responses to death decisions. I know that in the Caribbean, it would be not, it would be similar to our sisters and brothers here, insofar as people don't really want to talk about it. It's like if you talk about it, somehow you're gonna make it happen, kind of these kind of ideas, right?
Yeah.
So, and we know that it's the case, African Americans talk about this as well, it's across the African diaspora.
Yeah.
But as a sister who grew up in many places in the African diaspora and as a clinician, would you share with us whether you feel that that is a similar experience, or give us some insight about your experience?
Right, I would say it's very similar.
Mm-hmm.
And if you do talk about death,
Right.
back home, it's not heard of, like people don't want to talk about it. There's so much fear about inviting death in premature. And so it is the same.
Yeah.
And who wants to have that conversation when it's needed? Like even in my family, my parents are up there too, but who wants to have that? Who wants to start it? Because then there's so many proverbs that will be given in one setting. Like so many things that can be said. Don't talk about it. When it happens, we deal with it. But right now, we just want to be able to enjoy the people we have and not think about them leaving. But being here, I've come to see the relevance. And every now and then, like today, when I have a conversation with my siblings, and they're gradually warming up to it, but it's not really talked about. Even life policies where people have funeral plans. If they do that for their parents, they won't tell them.
They will, yeah,
No.
I didn't tell.
Because as soon as you tell them, they will think you want them dead.
Yeah.
Right,
Yeah.
so people
Mhm.
do funeral plans and all that, and they don't share. Because they don't want the parents to think that, oh, you're wishing me dead and all
Yeah.
that, so it doesn't. And in my experience here, even working in long-term care, I've had people with African ancestry come in, and usually there is no plan. And sometimes you would see that they really do not need to be resuscitated because of age and illness and all, but there's nothing. And most of us really hold on so much, we're afraid to let go, and no child wants to make that decision. So we keep doing CPR and all that when it should be just let them go.
Yes. Yeah.
So it's helpful to have that plan in place, make it easy for your children to let go. Or your siblings, because we have younger people in long-term care who have suffered strokes and all that,
Yeah, yeah.
have no quality of life, being in a chair all day, tube fed and all that. So if they go into crisis, the families always hold on and are afraid to say, yes, let them go. But if they're able to have that open discussion, if you have family in long-term care or in terminally ill, you are comfortable to say it's okay, let them go.
Yeah.
Because of the quality of life that
Yeah.
they might have when you hold on so much.
Yeah.
Thank you so much. I think that my assumption then that it is a shared, very commonly shared experience across our people, that is true. You know, we're hearing that. Let me ask something else though, because for many of us, the whole question of our faith perspectives are so strong that perhaps it would be the spiritual leaders or the faith leaders among us who could really help with these conversations. What do you think about that? What do folks think about that? That maybe this is an area that we could ask more of them about.
Yes.
What do you think?
I agree.
Me too.
I know in her church, Beachville, we've had estate planning, we've had directors come in.
Yeah.
It's been part of our church family
Yeah.
to talk about it. Purple Shields come in to talk about
Okay.
different things, and Josh Crawford, who's a funeral director at our church, comes to talk about cremation and to get your will and stuff in place. We actually partner with a law firm that for every person in the congregation that got their will done, they donated a certain amount of money back to the church. So we kind of use it as a fundraiser.
Yeah.
So people wanted to contribute, or they wanted to get their wills done and to get their funeral plans done, because it was putting money back into the church. So we used it as a way for them to come and get their will done, but then they were supporting the church.
Sure.
Yeah.
So that was a nice way to get it, and they came, I was gonna be around food and have sociables, but a lot of people got their wills done, and some of them did their funeral planning. And it was in a setting where everybody was comfortable talking about it. So you weren't sitting in your home by yourself, with your loved one. You're sitting with everybody that was thinking this. So we're all gonna plan together. We're all gonna go through this paperwork and realize that, as you said, Melinda, we're all gonna die at some point in time. So if we can plan together as a group, it's comfortable place, comfortable conversation. You're doing it in the church. So where else would you feel more blessed?
That's right.
Than doing something in a
And I
church setting.
think it's what Melinda said before, the more we talk about it, the more we normalize it. It doesn't feel so like you're betraying people.
Yes.
You're talking about something, I know in my family, it was always something, you mentioned that people got a little sensitive. So,
Yeah.
And if it's in a place where you're surrounded by people that you know and care about, it's a comfortable, it's safe.
In my family, the assumption is the oldest girl makes all those decisions,
Yeah.
Yeah. Me.
I think many of our families do expect that.
Yeah.
The older sibling, not maybe the girl, but the other sibling, for sure. I can say.
That's all you should.
I can say with our mom, and Sharon, as you said, your mom's been on since 2017, mom just had her anniversary on the 9th for 2 years for us. And it was a blessing that she had everything in place. And, you know, but that's who she was, right? So there's some people, and she tried to encourage many of her seniors friends to do that. It helped that our nephew worked for Atlantic Funeral Homes too, because he really encouraged it as a family, and plus you got the 50% discount. So anybody that works at a funeral home, get your 50% discount. You know somebody.
Funerals are expensive.
They
just
are.
one thing.
That's right. Yeah, you can go, you know, from 200 to 10,000 for sure. So mom had everything in place. She paid off her funeral, you know, over 20 years or whatever. So she started at a young age, paying off her, I say young age, not at 80, but you know, 60s is still the young age.
It is.
So she knew she wanted to have that planning done, and she also had right up to her church bulletin, but she had everything done, so we didn't have to think about it. So as her children, we just had to honor her wishes and to be ready for that. So that made it easy. She knew who she wanted to sing. We had to contact everybody that she wanted to sing at the church. We had to make sure who the preacher was. It wasn't our church preacher at the church. We had to bring an invited preacher that she wanted. She knew what food she wanted, like where she wanted to help. She wanted to be laid out with her body, and then she wanted to be cremated. So that's 2 days, right? So there's different things that you have to realize to do. And their wishes, and people say, why are you doing all that? Those are your parents' wishes. So if you know what the wishes are, then you try to honor those. If you don't, then you are left with, what am I gonna do? And then you got 4 or 5 siblings or whatever, you know, what happens with death, the arguing and the fighting, and we done, and nobody said, my family would never do that. Don't ever think, don't ever think your family's not gonna do it, because I thought I had the tightest family in the world. And 2 years later, we're still fighting. We will settle it with God's grace, it will get settled. But it's very important, even as some of my age, as you said, with your children, and Maxine had mentioned too, her daughter being home, it's like important to talk to your children about that stuff. And the beauty of it is that if you plan for your funeral now, a $10,000 funeral now is gonna be $50,000 by the time you're ready to go.
Right.
So it's all about being a bookkeeper, it's about financial planning. Plan for it now, pay your $200 a month, and once it's paid, and you can take it wherever you want. If you tend to move, if I move to the States, depending on what organization you go with, your funeral expenses and money go with you. Like, you don't have to be in Canada, you don't have to be in Nova Scotia, you could be in PEI, New Brunswick, wherever, but you pay your funeral and that's taken care of. And that's one big, that's one big burden off of the family.
It is.
You know, everyone thinks, oh yeah, the city will bury me, they'll bury you in a pine box, and by the time you get the CPP money, the church ain't waiting for your money. The church wants their money when they bury you, which is unfortunate too. Sometimes our churches need to have money up front, and people don't realize that people do wait to get buried until insurance money comes in. So there's a lot of things you got to think about when you're burying somebody and loved ones. So the more that we pre-plan, the more that we talk to our community about this, the healthier we'll be, because it is about living well while you're alive, living well. So I think we need to use those acronyms, use that terminology, and talk about it more. About it's not about dying, it's about living well, right? And then dying becomes that much easier for us.
Very good points,
Wow, this is a real good round table conversation. And y'all are joining us from your table. So you can jump in. Y'all want to say, anybody want to share?
We just have a point from Rhonda in the chat here. She just said, I agree, but we cannot limit our conversation to the church alone to ensure equity and that we do not miss anyone.
Exactly.
Yeah.
Exactly.
Yeah, community centers, meet people where they are, for sure. Even our seniors.
You're right,
In
Ron.
Halifax, we have how many seniors complex in that little circle of Cottage Street? And we could go to every seniors, Gordon B. Eisner, Sunrise, you can go all of those places.
Y'all like to think we are.
Meet people where they are, for sure. Go to the, have sessions in the libraries. That's so true. Yeah.
And to that point, I'm aware of in the UK what they call humanist funerals, which are not faith-based funerals, and what that looks like and what that opportunity is. I know they exist here, but if you were to ask me, if somebody was to come to me and say, well, how do I navigate a humanist funeral? I never sent them to the UK because I don't know. But I mean, there's so much that we could talk about, could learn about, could be informed about, right? So yeah. And I know it's an uncomfortable conversation, but my goodness, we have we have such resilience and such, I don't know, innovation in our communities, right? I mean, just imagine being so together that you're gonna think about a fundraiser around this. I mean, I have never heard of such, but yet it makes so much sense.
But it does.
Right?
Yeah. The information you share.
Yes, and to share information and to be knowledgeable about what the opportunities are, and also what we will all face.
Yeah.
Right,
What we all
you know, yeah.
Yeah.
Emotionally, financially, right,
That's right.
spiritually as
Spiritually,
well, you know,
yeah.
how are we coming to terms with that in our own, with our own faith perspective, whatever it is, or no faith perspective, or whatever the option is, whatever your worldview is, we need to be able to talk about it and know about options. So, you know, this, I think this is the beginning of, as you have pointed out, something great. And we've taken it in our way, in our African way, we've taken it further than, than what's on the page. But I knew we would.
I knew that we would.
I knew we would.
I knew
That's how we roll,
Yeah.
right?
That's what we do. But we have to.
Yes.
That's how we roll.
Yes.
That's how we have to do it.
Yeah, one thing I like to say, I heard Mom's last month.
Yeah.
I mean, we knew she wanted us to die at home, and we wanted to do the best we could, but sometimes as children, we do get tired. It's a lot of work, so we were looking, so the hospice conversation didn't come to us until late. So I think that part of the hospital, we had great doctors that worked with us, but they didn't tell us about hospice nor give us pamphlets until probably their last couple of months. Like, we should have had that, we should have that early on when we know that someone's diagnosed and it's gonna be terminal. I mean, obviously it's gonna go within some, we don't know, if it was a year, 2 years, whatever, or 6 months. But we probably could have thought about talking to her a little bit more about, well, when it gets too difficult, excuse me, is, we may have to do this, we may have to put you in there, or, none of us really want to, but I think that we had it on. And the thing that afterwards we read about it was such beautiful things that they were offering. There's such good care in hospice. Like, you get the feeling that it's not good care and that's not good location, and plus all the benefits that come with it, because they also gave you respite and different things that come with the hospice care.
they do.
And a lot of people don't know that. So I think that hospice doesn't have the word not out there about what they have to offer. And it's in free services too. Like, we don't realize that it's, also paid by through our taxes, of course, things that we do, but not realizing that it's something, it's an option.
Yeah.
So that option wasn't given to us until really late in her last days. But we would have been able to make other decisions early on. Mind you, we wanted to stay with her, but you're right. And then when we gave the stats about 70% don't verbalize. That was one of the hardest things. The way she stopped talking. Yeah, and you didn't know what to do, and you don't know how to help them. And it's like, well, do you want to eat? Do you want to go to the bathroom? And then so she just laid there. Just nothing. Yeah.
You made a very valid point about hospices not getting the word out about what they offer. We have our organization has a hospice council, and we have all the hospices, one person representing all the hospices. I will take that message back, and I'm sure that it will be discussed among the hospices. How can you get the message?
Yes.
As we have representation of all of them at the table.
Okay, that would be very helpful. Thank you.
But Anne and Allison, please do jump in though and define for us what hospice is. Because not all of us understand.
There's,
So what
it's
does?
hospice palliative care.
Yes.
And I'm gonna use my own personal example to help you understand. Palliative care. Here we go again. I think
You're having a crowd anxiety.
No, you people are not at all intimidating. I'm quite enjoying the conversation. Palliative care is when you have beds set aside within a hospital setting to care for people who are in long-term. Palliative care puts you into a situation where you have much more of a home life. You don't have people running around, you don't have bells and whistles and all the sounds that go on in the hospital. It is intended to be a much more warm and welcoming place. Your family's free to come in. The rooms are not hospital rooms. I know of situations where, they make meals for them, whatever you want. I remember a friend of mine telling me that she works at in the kitchen at the hospice here in Halifax. And she had one gentleman who just wanted fish cakes. And she made fish cakes and brought them into. So that whole atmosphere is very different. Now, the reason I probably am most partial to hospice as opposed to palliative. Palliative, my mother was in palliative when she was passing. She was in the same room with someone who had a diagnosis and a care plan. When you go in and you've all been in hospital, probably you've seen someone's name, it says in the charts. By my mother's name, it says comfort care. We just want to keep her comfortable. And yet she's surrounded by people trying to preserve life. And I felt that was so sad. That made me very sad to think that my mother was just there. They weren't going to do anything. They weren't cruel. They didn't do anything. But she was surrounded by people trying to save lives. But they accepted that hers is over. And that I couldn't even look at it when it said comfort care.
Yeah.
So that's the difference between palliative and hospice. We do not have near enough hospice places. That's the problem. And in a lot of smaller communities in Nova Scotia, we don't have any. So all we have is palliative care beds. Most hospitals have a couple of palliative beds designated.
Yes, that's what they do.
So, and that's how it works. So I think ideally, our goal should be to have a lot more hospice available than palliative. But I wouldn't fault, palliative is what you need when it's too much for the family to look after that person. And that's the way, so.
And what occurs to me, and my Hawk family will know that I'm gonna say this, is we need hospice that looks like us. In order for us to be comfortable going to hospice, we need people who work in hospice, who reflect who we are. And it's gonna be, and we make it culturally specific and culturally competent, so we know that you know what you do in the course of a day, how the music that's played,
Absolutely.
the surroundings that are going to look different. So in our outreach to hospice, and you say you want to do that, and I trust that you will, but it is important to say to them, cultural specificity is number one. If you want us to be there, then you gotta make it so we can be there. So that's part of it, but and also just even the notion of understanding, because what you've explained tonight is so important. I really know the difference in the way that you describe it, right? And so again, there's so much to learn and understand, but we can take these conversations and explore them differently. Right. So we've had a really good time together. It's 8:07. It is a little bit earlier than we have time, but I do want to make sure that everybody has a chance for a last word who are joining us in cyberspace. I guess, can I say that? Did I say that correctly, Carl? Because I don't know quite what the terminology is, but yes, Rhonda has the last word.
Well, I don't know if it's the last word because other people might have something to say, but I just wanted to not necessarily ask a question, but just contribute a little bit to what you were saying around representation. Representation, I think, is really key. And also understanding the difference between hospice and palliative care, doing some of that education in community and what that means around choices and decision-making, I think is really important as well. So, thank you all. I just wanted to say this has been really informative, very important, and let's keep the conversation going. Thank you.
Thank you, Co.
Thanks. Thank you.
Others? Don't leave a sister hanging now. Come on.
I just wanted to say it was very informative, very useful, and I agree, we need to keep this conversation going. It's something we shy away from, we realize, so it's important to, have it open in such a way that people feel safe to talk about it. So thank you, thank you.
Thank you, Sister Maxine.
Thank you.
Thank you so much.
Thank you.
Last word from Dr. Leah. Do you think we can bring this into the structures that we have, the evolving structures, without not putting too fine a point on it? We have sisterhood and brotherhood. There may be opportunities for having conversations like that connected to the work of our primary healthcare people. What do you think about that? Be good?
I was thinking about that as well, right? That could be definitely easily incorporated into, one of the clinic days, right? Somebody could just come in and say, I just want to talk about it, right? You don't have to make it all in that one visit. You can start even just having a conversation, understanding the conditions they have, right? Like, can we talk more about my diabetes? Can we talk more about my heart condition? I think that's a great idea, and we could definitely incorporate that.
Yeah. Wonderful. Anyone else? Anyone else in the room? Come on, don't be shy now. You haven't been shy up to now. All right. Well, I'm going to turn over to Melinda to say goodbye, but I want to thank you all so much for we do have.
That's me, that's me.
Okay.
Never way over. I'm going to leave some information with you, and this is one that I find particularly helpful because it actually helps you to think about your plan. What's important, how important it is to be comfortable and suffer as little as possible. Questions that we have there, but we can't formulate. I'm going to leave a number of these copies and on what would happen if I was in a vegetable state or if I have a terminal. What kind of decisions? It helps to prompt the thinking. So you'll make. Afraid not. I don't have one. I don't know whether Anne would have one or
I
not.
think you should get it on the national. I don't have one locally, but
Yeah.
I'm looking at that and thinking we should do that electronically.
Yes,
You know
yeah.
what? I'm gonna take this one.
Okay, you take that one, but it does help you to go through the
I'll make
thinking.
it more.
Because it is an awkward subject, tends sort of home, we need to have that broad. So,
Right. Okay.
but all of the resources are available on, there's advancedcareplanning.ca.
Yeah.
And you can go there, that has all the resources. But if you have any other questions, certainly Anne can follow up for you.
Could I just add something here? Thanks to Carla's kindness, thinking about my wishes for future healthcare.
Yeah.
She's going to make sure that it goes on the website.
Yeah.
Perfect.
Right. So over to you, Sister Melinda.
I love it. Oh, what an evening we had.
Yes.
First step, great step. Thank you so much, all of you. Thank you here at the table.
Well, thank you, Melinda,
Oh,
because
thank you.
it was your leadership that brought it to be. And it really is, you got the ball rolling.
I got the
That's
ball.
admirable.
Okay,
And
thank
we're gonna
you.
keep it rolling.
And we're gonna keep it going. So it's all about conversations, it's about decisions, and it's how we care for each other.
Yes.
Conversations, decisions, and how we care for one another. Good
Well
night.
said.
Thank you so very much, and I
Thank
look forward to what's happening next. Good
Thank you
night.
all.
Good night, everybody. Good night.
Good night.
Good night.
Thank you, everyone. The recording will be shared on the Hawk website from tonight.
Nice. On YouTube, okay. Good night.